And Eileen, you've done some amazing research with the BRCA patients. So tell us a little bit about BRCA mutations in pancreas cancer of all things.
Yeah, so I think this is another exciting area that applies at least to a subset of people with pancreas cancer. So we know in unselected 100 patients with pancreas cancer, anywhere from 5 to 8 will have an underlying germline BRCA mutation, and maybe an additional 3 or 4 or 5% will have a somatic BRCA mutation. And 2 observations have been made. One, that platinum drugs have an important role here, and I think this is sort of expert opinion, it's not randomized data, would suggest that using those drugs in patients in whom we know that they harbor one of these mutations might be therapeutically important. I think the other area where there's a lot of development is PARP inhibitors, and we have PARP inhibitors being evaluated frontline in combination with platinum-based therapy, but also being evaluated as a maintenance strategy in germline BRCA following disease control with platinum-based treatment. But just thinking about the broader group of patients with pancreas cancer, we know there are a number of other germline defects that occur, and ATM is pretty common, ATR, and other genes. And it's possible that maybe combinations of PARP inhibitors and other strategies, or PARP and immune therapies, may have a role in this subset. So I think there's a lot of interest in exploring this theme in pancreas cancer. We're clearly not there yet, but again, I think we'll be hopefully beginning to identify some groups of patients that we can refine treatment choices that are rational based on characteristics of their disease or genomics in pancreas cancer. And that will be, in my opinion, an important step in this disease.
So much happening, lots of research going on, different targets. I've also heard about STAT3 inhibitors trying to target the cancer stem cells being looked at for pancreas cancer. So trying to approach it from all different angles and aspects. George, any last thoughts on trials that you think are interesting?
Well, it's what we said earlier. I think we still have a lot of work to do. We've got to get these trials accrued. We've got to support the intergroup trials and really continue to move the field forward. I think we still have a lot of work to do. Patients are demanding it, and we need to come to the plate. So. Yeah.
Well, I think this has been extremely informative. So before we go and before we end this discussion, I'd like to get some final thoughts from each of our panelists. So George, I'm going to hit back to you again. Any last thoughts outside of what you just said?
Well, I enjoy being here. It's fun. There's a lot of banter and a lot of expertise, but I hope it's helpful. And again, hopefully we're helping our patients. And just to remind everybody, you've got to manage these folks.
Yeah.
Nutrition, pain control, diabetes, intestinal, psychosocial, very important. And then run with the drugs as best you can, and try to get the most benefit out of these agents. So.
Excellent. Dr. Rocha Lima?
Yeah, pleasure being here in such great company. But one other issue that I want to bring up is that being in academia before and now being in private practice, the importance of subspecialization. As I moved on from academia, that we are all subspecialists, and we go into private practice, and I realized the importance of continuing to be a subspecialist. And I think that the community has to realize that not every pancreatic cancer is the same. And I'm still learning with every single patient that I see, but I feel much more comfortable seeing GI cancers than any other subspecialties. And I think I can take better care of the patients that I see more often.
There's so much to know now.
Absolutely.
It's incredible. Dr. Marshall?
Yeah, you could go on any angle with pancreas cancer as to what we need. Everything from a screening tool maybe to find early detection for this cancer, but clearly it's a systemic disease early, and development of new agents. So I continue to beat the drum of we need to understand the biology of this cancer, and your allusion to the tough nut, we need to get into this thing, study it, invest more money in it. You know that I feel very strongly about the imbalance of research funding in our country, and organizations like PanCan and others have really helped change that. Lustgarten. We need more of that if we're going to do that. I think Eileen referred to it earlier that this will soon be the second leading killer because other things were doing better, even though it's not that common of a disease. So let's do everything we can to not meet that mark.
I love that. Dr. O'Reilly.
Yeah, and I echo all the sentiments that's been presented and love the humor. But just to endorse what's been said, I think moving the field forward is new drugs for our patients and clinical trials, and I really believe that's going to someday hold high gain for this patient population, and that we have not to get discouraged, and even though it's hard, but it's so important that we really focus our efforts in terms of understanding this disease and in terms of clinical trials. And John said funding, I couldn't agree more, that there's many opportunities that I think need to come the way of pancreas cancer, but there's a move. I feel it.
I love it. Well, thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.